Assalamu alaikum. Welcome to the Surgical Retina Symposium. Welcome, madam. I invite our first presenter, Professor Tariq Khan Marwaz Saab, and he's talking on rheumatogenic retinal treatment, detachment treatment, and logarithm.
Okay, so the treatment of rheumatogenic retinal detachment goes back to 1920. Jules Gonin was the one who is rightly known as father of retinal detachment surgery, and he was the one who appreciated the significance of closing the retinal breaks for the first time. After then, the concept of scleral buckle was described by Custodes, and then Skepan's era came from 1950s. He introduced indirect ophthalmoscope, he refined buckling and devised encirclement, which is still being used as a primary treatment for retinal detachment. Kibis introduced silicon oil as a tamponade. Lincoft devised the rules and principles of how to find retinal breaks. He also introduced cryotherapy, and he was the pioneer of silicon sponges. After then, Macimer introduced pars plana vitrectomy, Norton introduced SF6 gaze, Gilbert introduced DACE procedure, Stanley Chang introduced PFCL for the first time, and then the era of small gauge vitrectomy came. The principle of treatment of rheumatogenic retinal detachment is the same as described by Jules Gonin almost 100 years back. The principle is to identify and localize the retinal breaks, to release any traction, to drainage the SRF, to perform retinopexy by laser or cryo, and then to use tamponade external and internal. The earlier the retina is reattached, the more likely the functional improvement will be complete. Delaying the surgery increases the risk of PVR. Whether RRD is a real-time emergency or not, this is still controversial. For macula on RD, surgery should be performed within a day. For macula off RD, intervention can be delayed by a few days, but should still be performed within a week. Choice of surgical technique depends on characteristics of RD, peculiarities of individual patient, surgeon's preferences and experience. Amongst the techniques, scleral buckling is the oldest technique. Pars plana vitrectomies and other pneumatic retinopexy can be used in selected cases. There is a new technique, the suprachoroidal viscopexy, that can also be helpful in selected cases. Laser barricade and observation, they are treatment of choice in exceptional circumstances. Scleral buckling is a reference technique for uncomplicated phakic retinal detachment. It is very effective in inferior dialysis detachments. It should not be considered for more posterior breaks, for GRT cases, for previously performed trabeculectomy, strabismus surgery cases, for media opacities and complex retinal detachments. Indications of scleral buckling include radial buckle should be used in horseshoe tears in relatively posterior breaks. Segmental buckle should be used in single or closely spaced breaks within 1 clock hour, in anterior breaks and in dialysis cases. Encirclement plus minus tire is a choice in multiple breaks cases in different quadrants, in aphakia cases, in pseudophakia, in myopia, in lattice, and in extensive RD with detectable breaks. Whether SRF should be drained or not, SRF should be drained in bullous detachments, in inferior RDs, in immobile retina, and in long-standing retinal detachments. The purpose is to allow elevation of buccal without elevating the IOP. Pars plana vitrectomy is the first choice of treatment in primary pseudophakic retinal detachments, in re-RDs, in failed buccals, RDs with media opacities, in advanced PVR cases, in breaks too posterior, too large, too many, retinal detachments with giant retinal tear, retinal detachment with full thickness macular hole. Vitrectomy performed alone or in combination with buccal. The gauge depends on surgeon's decision. 25, 23 gauge, 27 gauge in some cases is usually used in these cases. Complete vitreous removal with extensive base shaving should be the aim. Triamcinolone alone can be used to visualize the vitreous. SRF is drained through the break, during fax, or with a separate retinotomy. Laser should be applied around the break. Sometimes some surgeon will do prophylactic 360-degree laser. A non-expansile mixture of gas or silicon oil prevent fluid access to the retinal break until retinopexy seal takes effect. Eye should be positioned post-operatively and IOP should be monitored. Transconjunctival microincision vitrectomy surgery. The advantages include that it is a sutureless procedure, so better patient comfort, shorter surgical time. This is a query mark. Less inflammation, faster healing, less surgically induced refractive errors, no conjunctival scarring, useful for patients requiring multiple surgeries like glaucoma surgery, less chance of iatrogenic oral breaks. Ports design helps in more complete vitrectomy and better dissection of the membranes. Some of the surgeons do vitrectomy with buccal, and this may be a choice in cases of PVR, GRT, peripheral uveitis, viral retinitis, ROP, and peripheral retinopathy cases. Some will prefer retinectomy in place of buckling with vitrectomy. Pneumatic retinopexy is a minimally invasive OPD procedure. It's a favorable success is there in fresh phakic RDs performed in a single or two steps. Post-operative position is very crucial and case selection is key. Can only be performed in fresh RDs, small breaks in less than 1 clock hour, and breaks must be in superior 6 clock hours. We performed a retrospective patients file review. All patients operated for RRD from April 2017 to April 2025. 2,236 eyes were included. The type of RD procedure performed and post-op retinal status was documented, and primary reattachment was found in 1,849 cases. The algorithm is that for primary phakic RD, scleral buckling can be the first option. Some will suggest PPV plus gas is the first option, and some will prefer PPV plus oil. Primary pseudophakic detachments, vitrectomy with gas is the priority. Cases is proved by different studies. But encirclement plus minus tire can be an option. Vitrectomy with oil can also be an option. RD with inferior dialysis. In these cases, buckling procedure is very effective. In our studies, 95.8% success rate after single surgery was documented. RD with GRT can be treated with PPV plus gas or oil base shaving anterior retinal flap removal. PPV plus oil plus buccal in certain cases where PVR is there. RD with inferior breaks, buccal alone can be effective. Sometimes we can decide for PPV with gas and sometimes PPV plus oil. RD with PVR, buccal alone if there is subretinal bands and it is not affecting the macula, and in selected cases we can perform buckling, but vitrectomy with oil or gas, vitrectomy with oil or gas plus buccal, and in certain cases retinectomy is needed. RD with the full thickness macular hole, the standard procedure is PPV plus ILM peel plus gas, but in certain cases oil can be used. In bullous detachment, Days procedure can be effective, but usually we perform pars plana vitrectomy with gaze. RD with soft eyes vitrectomy is the only option, uh, plus minus augmented buccal. RD with thin sclera vitrectomy plus gaze or oil. In pediatric detachments, we usually try to perform buccal, but in some cases, vitrectomy is inevitable. RD with IFB vitrectomy plus gaze or oil. So the key points in successful retinal detachment surgery is they localize all breaks, remove all the traction, meticulous base shaving, adequate retinopexy, adequate tamponade fill, and also I have included this point that quality of tamponade is also very effective. The purity of silicone oil, the inertness of the internal tamponade is also very important. And definitely the post-operative positioning. So in conclusion, there is no globally agreed standard of care. There is no clear consensus regarding the optimal treatment. General trend is towards PPV as the primary procedure. Fundamental goal is to identify and functionally close all breaks. Choice of surgery depends on surgeon's training, preference, and experience, and also depends on equipment available and the changing contemporary practices. Thank you very much.
Thank you, sir, for completing the presentation on time. Now, our next speaker is Dr. Shahid Abdurrauf Khan sir. He has come all the way from Peshawar, and welcome, sir, to Lahore.
Thank you, sir, for introducing me. Most of the points have already been discussed by Professor Tariq Marwat Saab, so I'll be going to only those points in which I would like to lure you people into buckling procedure. I'll start with my presentation with this picture as a patient, pseudophakic patient who presented with superior bullous detachment with superior temporal quadrant horseshoe tear. So should we go for buckling procedure or vitrectomy? Both choices can be a good option. Scleral buckling with 5 millimeter radial sponge with SRF drainage is also a good option. Again, vitrectomy can be a good option with gas, C3F8 gas, because the break is superior. Uh, the PubMed search revealed that we are going towards the vitrectomy rather than the buccal procedures. Since 1956, about 2,800 articles were published on scleral buckling, while 12,000 articles were published on PPV and 1,073 with combined procedures. This trend has changed a lot, and you can see the difference that during recent years, only 400 articles were published on scleral buckling, while 3,000 were on pars plana vitrectomy. This shows the trend change towards the pars plana vitrectomy. More than 10 times PPV is performed as a primary surgical procedure for retinal detachment, and in Western countries, more than 80% of the patient they undergo PPV rather than buckling procedures. There are few assumptions that makes the surgeon tempted towards the pars plana vitrectomy. Some of these are that one is the success rate of scleral buckling is less as compared to pars plana vitrectomy. Secondary interventions, they are more frequent after scleral buckling procedures, and there is high induced astigmatism after buckling procedures. Uh, there is high incident of complications, especially if you do drainage with drainage. So the complication rate increases, and they may be devastating. Higher PVR, especially if you do buckling procedure combined with cryotherapy, so PVR incidence raises. And one of the most recent assumption is that pars plana vitrectomy, especially with the newer systems and the viewing system, it is easier to learn as compared to buckling surgery. So there are few points which shows that this art is now in a dying state. Number one is the lack of training, especially by the new supervisors who are born in the PPV era, who are less trained in the buckling procedure. So the training is lacking, lack of intent to hard work, better surgical result. There is perception that pars plana vitrectomy may give you better results as compared to buckling procedures. Better ergonomics on part of surgeon with vitrectomy as compared to the buckling procedures. One of the most important point in order to achieve surgical success through buckling is the thorough preoperative fundus examination and drawing your examination findings with the indirect ophthalmoscope, which takes a lot of hard work, and it is very important for scleral buckling procedure. Most important, last but not the least, the industry influence, because there is more the companies, they promote vitrectomy platforms more as compared to the buckling procedure due to uh, high profit, and the buckling procedures, they are relatively inexpensive and they have very low profit profile, so they are not aggressively that much marketed as compared to the vitrectomies. Some of the retinal detachment scenarios, they are still the best option would be a buckling procedure, even if the center has more PPV surgeons. So these are the fresh retinal detachment with very minimum PVR, young patient who have formed vitreous and no PVD, single break like the one I showed in first slide, or breaks that are multiple but they are very adjacent, especially if they are at the same distance from the limbus. Phakic patient in which vitrectomy is difficult to perform with the high risk of lens touch, and high myope patient in which there is very difficult peripheral shaving, especially over the degenerations, and especially if the retina is very mobile. And one of the best option for buccal procedure, as Tariq Marwa Saab said, is the retinal detachment due to retinal dialysis in young patient with no PVD. The factors that tends the patient towards the internal approach includes pseudophakia or aphakia, multiple breaks, which involves many quadrants, especially if they are at multiple distances from the limbus, retinal detachment in which break cannot be localized, previously failed scleral buccal procedure that is obvious, and any media opacities, for example, asteroid hylosis, cataract, vitreous bleed. So they may tend the surgeon towards the internal approach. So the PPV basically it has better suitable for those patients in which there is giant retinal tear, retinal detachment in myopic patient which have choroidal detachment, those patients that are high PVR, especially with star folds and retinal shortening, eyes in which already buccal has been performed and they have retinal or vitreous incarceration, retinal detachment in which there is media opacity, for example, asteroid hylosis, vitreous bleeds, and cataract with poor view, and posterior breaks if your buccal cannot reach it, especially the radial one. Sometimes large retinal dialysis, it's very difficult to buckle it because of the sagging of the central portion of the dialysis. If the dialysis is more than 90 degree or some say 180 degree, it's good to do pars plana vitrectomy in those cases. I would not be going into the steps of the surgery, but I will give you a few practical steps just to lure you people into buccal surgery. As already you know, there are four basic protocols, that is localization of the break, aseptic inflammation, sealing the break, and drainage or no drainage. So what things should be done in order to have a low incidence of complications and higher rate of success in buckling procedure? First and foremost is to practice retinal examination with indirect ophthalmoscopy, which takes a very hard work, and also with indentation. This is very important because if you want to have a higher success rate, you should see all the breaks. Just on the day of the surgery, just before the surgery, immediate pre-op examination is very important, especially if the patient has taken rest overnight. uh, Drawing pre-op examination findings on a paper, and especially if the patient is under local anesthesia, always reduce the intraorbital pressure, just like you do for the anterior segment surgeries or cataract surgery. It will help you in the maneuverability, easy maneuverability during the application of the buckles or stitching. No drainage surgery. If you are not planning to do drainage, then always do AC paracentesis to lower the pressure for maximum buckling effect. Uh, if you are doing drainage, then always drain before the buccal placement. You can drain with cut down or with prang technique. If you are doing cut down technique, always relieve pressure before the SRF drainage. because it will help to reduce the retinal incarceration. And also, if you are doing cut down technique, always do cryo. Sorry, the choroid should be cauterized before drainage. That will reduce subretinal bleed chance. If you are using any fluid, or fluid should be used to compensate for the hypotony after drainage, because the air will lower the visibility, and this is a good option for a beginner surgeon. Some practical tips that should not be practiced is: number one, always don't stop looking for secondary breaks, because one of the most common uh, failure chance for the buccal surgery is the missed breaks. Uh, don't drain always. Sometimes you may get good results without drainage techniques. And don't over tight the buckles, or especially the encirclement bands. And it is very common with the beginner surgeon. Never ignore central retinal artery perfusion at the end of the surgery. Remember, the detached retina does not need buckle. Only the breaks needs buckling. And always remember to cover secondary breaks. And if the retina is flat, it does not need any cryo or laser. And if you have flat breaks or lattice, always do 360 degree cryo or laser. And if you have hypotony, inject air before tying the buckle to avoid over tightening. This is our experience at Hyderabad Medical Complex in previous years. Since 2003, 80% we had success rate. That was published by Dr. Sanaullah Jan Saab and Dr. Tariq Marwat Saab. At 2010, the success rate reached 85%, 95% with retinal dialysis, and with no drainage technique, it was 91%. Also, the buccal surgery is cost effective. Like you need only simple microscope, while for vitrectomy system is needed, posterior segment microscope, weaving system is needed, and endolaser system is needed. So for vitrectomy, you also need cassette cutters, endolaser probes, endolites, trocars, and the consumables are also very expensive. You only need simple buccal for the buccal surgery. So to combine these costs, you can do 10 to 15 scleral buckles for the cost of only 1 ppv if you exclude surgeon charges. One of the most important thing regarding buccal surgery is the neck pain and the lower back pain. And I have two words for these pain. One is exercises, which will take only half an hour, 15 minutes for the neck and 15 minutes for the lower back. And second one, and then if you add gym at weekends, Saturday, Sunday, that will be Sone Pe Suhaga. And third one is the chandelier assisted buckle. It will also reduce these threats. If you see the patient with such a beautifully attached retina on the next very day, I'm sure you will forget all the pain. So to conclude, the buccal surgery is a very safe and effective procedure, very cost effective, especially for our country. And it's needed that young ophthalmologists should be trained in this procedure. Thank you so much.
Thank you, sir, for tips on the scleral buckling. Our next presenter is Dr. Bilal A. Khan, and he will be talking on intraocular gases. The sir has come all the way from US. Welcome, sir, to Pakistan, and thank you for coming.
Assalamu alaikum. So I'm going to talk about intraocular gases. Some historical background. Gases were first used by Ohm in 1911. He used a sterile air injection in 2 patients with retinal detachment and reportedly reattached 1 patient. So that's a 50% success rate. Then came 1938 when Rosengren used external diathermy with drainage of subretinal fluid and internal tamponade by air to treat patients with retinal detachment. Fast forward in 1980s, Linkoff and subsequently others introduced concept of pneumatic retinopexy with use of pure expansile gases. So gases which are evaluated for vitreoretinal surgery fall into 2 categories. There are non-expansile gases. Prime example is air, and then there are a variety of expansile gases, including sulfur hexafluoride and a bunch of perfluorocarbon gases, the most common being perfluoropropane. These expansile gases are used in their pair form in procedures during pneumatic retinopexy, but during vitrectomy procedures, pure gases are mixed with air in appropriate ratio to produce non-expansile concentrations. Looking at physical properties of the commonly used gases, air when injected into the eye does not expand, lasts about 5 to 7 days. Pure SF6 expands twice its size in 1 to 2 days, but lasts about 1 to 2 weeks. Its non-expansile concentration is about 18 to 20% when mixed with air. C3F8 expands 4 times its size in about 3 to 4 days, lasts about 6 to 8 weeks, and its non-expansile concentration is 12 to 14%. It is notable that SF6 is about 5 times heavier than air, whereas outer perfluorocarbon gases C3F8 is 6 times heavier than air. What is the functional role of the gas bubble in the eye? It provides internal tamponade due to its surface tension, which is highest of any vitreous substitute. This surface tension prevents breakup of the gas bubble and its entry into subretinal space. Due to effective seal of retinal break by this gas bubble, passage of fluid from vitreous cavity to subretinal space is blocked, and existing subretinal fluid is then absorbed by RPE into choroid. This gas bubble also provides buoyant force, which pushes fluid out of retinal breaks. This force is greatest at the apex of arc of contact of gas with the retina and is 10 times greater than equal volume of silicone oil. Gas bubble also acts as inert body, causing compartmentalization between retina and subretinal space. As a result, proliferating cells and growth factors can no longer escape from the subretinal space into vitreous cavity and settle onto retinal surface. This has possible role in preventing PVR. So earliest PVR is usually seen in the inferior retina, where all these elements gravitate and gas disappears first. 3 phases of gas expansion and resorption are seen after injection of a pure expansile gas. First phase is bubble expansion, in which nitrogen, oxygen, carbon dioxide, and water vapor comes from vitreous cavity into the gas bubble. Second phase is nitrogen equilibration, in which the net loss of the gas is balanced by nitrogen uptake. And then the third phase is bubble dissolution, in which all these elements leave the gas bubble and gas is slowly disappeared. Bubble expansion, remember, on a pure gas is fastest in first 6 to 8 hours, and this is important for eye pressure monitoring during this time. Several factors can affect the gas bubble dissolution after gas bubble is given, such as presence or absence of vitreous, lens status, aqueous hemodynamics, ocular blood flow, and elasticity. For example, half-life of sulfur hexafluoride and C3F8 in phakic non-vitrectomized eye is about 2 to 3 times longer than phakic vitrectomized eye. When intraocular gases are used, there are special considerations regarding the use of nitrous oxide during general anesthesia and air travel. Nitrous oxide, which is also known as laughing gas, is a highly soluble gas. The high solubility of nitrous oxide results in its rapid influx into gas bubble with expansion of the gas bubble. As a result, the intraocular pressure can increase, and this maximum increase is usually within first 15 to 20 minutes. So if intraocular gas injection is planned, use of nitrous oxide in general anesthesia during any ophthalmic procedures should be avoided. But if somehow you are using nitrous oxide during ophthalmic procedures, it should be discontinued 15 minutes before fluid-air exchange. Because of a short half-life of nitrous oxide, alveolar concentration of nitrous is generally reduced 90% within 10 minutes, and then you can use the nitrous. You can use any intraocular gas. Wristbands with warnings of potential hazards of subsequent general anesthesia using nitrous oxide should be worn by all patients with intraocular gas bubble. Severe vision loss and central retinal artery occlusion have been reported in patients with intraocular gas bubble when general anesthesia with nitrous is used for any subsequent non-ophthalmic surgical intervention. Under the principles of Boyle's law, pressure and volume are inversely proportional in relationship to the gas. So rapid decompression of the atmospheric pressure during ascent of the airplane can result in expansion of the gas bubble, with again resulting increase in the intraocular pressure, which can cause central retinal artery occlusion. Air travel is generally prohibited till the gas bubble is completely dissolved. Some animal studies have, however, showed that you can leave up to 10% of the gas before a safe air travel can be done. In cases of emergent air travel needs, gas bubble can sometimes be removed in clinic. This is particularly hard in phakic patients, but pseudophakic patients, you can make them recline back and remove the gas bubble with a needle behind the IOL. Post-operatively, prone position should be maintained after vitrectomy with gas in the eye. This position helps chances of cataract formation, pupillary block glaucoma, and corneal endothelial decompensation. Other specific head positions may be needed after pneumatic procedures based on the location of the brakes. When expanding concentrations of the gas is used, intraocular pressure should be monitored for 6 to 8 hours. Sometimes you can prophylactically treat with Diamox or other anti-glaucoma medications. Examination of the patients with an intraocular gas bubble is best done with 28 or 30 diopter lens. Patients should be examined in several positions. First, sitting upright with chin level so you can determine the percentage of vitreous cavity filled with the gas bubble. Patient can be examined sitting upright while he's looking down, and you can look at the inferior retina looking for any evidence of recurrent retinal detachment. With a small gas bubble in the eye, patient can be reclined back in supine position, and the gas bubble will fill the pupillary space, and reflections from the interface of the bubble are reduced for better visualization. There are several complications of the intraocular gas use which are possible, and we'll go through each of these individually. Elevated intraocular pressure in glaucoma is seen in about 25% to 60% of the patients. It's more common with pure gas or higher concentration mixtures. Generally, this intraocular pressure can be controlled medically. If IOP is difficult to control by medical means, outflow compromise due to peripheral anterior synechiae or angle neovascularization should be suspected. If somehow pupillary block glaucoma happens with forward displacement of lens iris diaphragm, it should be treated with aspiration of a small amount of gas bubble through pars plana, and afterward patient should be in prone position so that there is no recurrence of the problem. Hypotony after gas bubble can be due to transient leak at the end of the procedure due to the manipulations or post-operative period. Usually observation with medical management is enough, but if there is prolonged hypotony, there is risk of choroidal effusion and hemorrhage. Lens opacities after intraocular gas use are usually feathery, posterior subcapsular opacities or posterior subcapsular vacuoles. Mostly they are in the superior part of the lens and often, fortunately, are transient. Prone position again helps in prevention of some of these opacities. In aphakic and pseudophakic eyes with poor zonules or open posterior capsules, gas migration into the anterior chamber and contact with the corneal endothelium can act as a mechanical barrier. As a result, there is poor aqueous and oxygen access to the endothelium, which can lead to corneal endothelial decompensation and bullous keratopathy. So prone head position also helps in prevention of this. Subretinal gas migration and new and enlarged breaks are usually seen after pneumatic procedures. Risk factors for subretinal gas migration are large breaks and presence of multiple fish egg bubbles. One problem is that expansion of the subretinal gas can convert a macula on detachment into macula off, and sometimes when the gas expands to subretinal space, it can lead to stretching of the fovea, leading to a full thickness macular hole. Usually subretinal gas is managed by surgery, and rarely head positioning can also work to push this gas from subretinal space into vitreous cavity. New and enlarged retinal breaks are due to vitreous movement. Superior breaks can be managed by modified head positioning to cover the new breaks, whereas inferior breaks, especially if there is any fluid present, would usually need surgery. IOL capture usually happens with combined phaco-vitrectomy cases, or if the vitrectomy follows after a complicated phaco case. Intraocular lens can be pushed forward towards the anterior chamber by the gas bubble in the posterior chamber, leading to optic capture. Prevention involves smaller capsular axis for combined cases, as well as avoiding supine position in the post-operative period. An entity to mention is ocular venous embolism, or presumed air by vitrectomy embolization syndrome. This is a rare fatal complication of air fluid exchange during vitrectomy. So far, 13 reported cases in literature, and unfortunately, 9 out of 13 cases were fatal. Improperly positioned or slipped infusion cannula during fluid air exchange phase of vitrectomy can cause pressurized air into suprachoroidal space, which can lead to tearing of vortex veins. Air goes into the systemic venous circulation, reaches the right side of the heart and lungs. Patient on the table will become hemodynamically unstable after fluid air exchange is initiated. Surgeon may notice a large choroidal detachment forming. Anesthesiologist may notice a sudden drop in end-tidal carbon dioxide. Air infusion should be immediately halted and resuscitation measures should be started. Prevention includes Prevention involves a timeout before starting air infusion to make sure proper infusion cannula position and make sure that infusion cannula has not moved into subretinal space. Thank you very much for your time and attention.
Thank you, sir, for updating us on intraocular gases. Our next speaker is Dr. Usman Mahmood, and he will be talking on vitrectomy and tamponades in retinal detachment and apnea.
Assalamu alaikum, ladies and gentlemen, and thank you very much for the invitation. Uh, basically, my talk involves the quite basics of vitrectomy in retinal detachment and tamponades and kind of an update. So, as we all understand, that retinal detachment can be rhegmatogenous, it can be tractional, it can be exudative. Rhegmatogenous, as we know, is because of the retinal break, which results in migration of the fluid or the vitreous cavity and causing the retina to detach. And it can be obviously because of a break, which can be tear, single tears, multiple tears, or dialysis. The tractional, on the other hand, results in the anteroposterior traction on the retina caused by multiple factors, which could be inflammatory or otherwise, which causes a mechanical traction and pulls the retina towards the central part. And obviously, sometimes we come across combined forms, especially in diabetics, where we can have a combined rhegmatogenous and tractional detachment, where there's not only traction, but the traction causes some breaks in the retina, that results in the fluid going behind it and causing a combined detachment. So the mechanics, again, just a basic review that a break in the retina can cause the fluid to go behind it and cause the retina to come off. And depending upon the location of the break, the retinal detachment can ascertain a certain form. So the exudative type is mostly inflammatory, where the inflammation in the choroid will cause the exudation of fluid under the retina, and it will cause the retina to get detached. So the purpose of retina reattachment surgery is to reattach retina with RPE so that it can regain its visual function. So what are the principles? The principles is to remove the traction wherever it is present, to make room in the vitreous cavity for the tamponades, identification and location of retinal breaks under the direct visualization, remove all the tractional elements of retinal shortening or membranes, etc., and to remove the subretinal fluid internally. The vitrectomy, as conventionally we started with 20 gauge. I don't think many people are doing 20 gauge these days. So we are on to 23 or 25 plus or 27. So the principle basically is to start with a core vitrectomy when you start the procedure, and the peripheral shaving of the vitreous space, trimming over the breaks, amputation of the flap, this is very important, and removal of the anterior retinal flap, especially in giant retinal tear. So here basically is just a basic step where we're doing the core vitrectomy. In the core vitrectomy, the settings are that the cut rate is the vacuum is higher with less cut rate, so that you can engage more and more of the vitreous. And obviously, once the core vitrectomy is done, then you address the break. So once the vitrectomy is completed, including the core vitrectomy and peripheral shaving, it is vital and to do the internal search. This is to locate the break or breaks, to evaluate the extent and the nature of the detachment, to evaluate the mobility of the retina, because that will determine at the end what kind of tamponade you are going to use. So now coming to the draining of the subretinal fluid, this is again a very important step. the internal drainage through the brakes or retinotomy, again depending upon the location of the brake, amount of fluid present. Uh, the if it's an interior brake, quite an interior brake, which is very difficult for have the subretinal fluid removed completely, then one can resort towards a small retinotomy just beside the optic disc where the maximum fluid is present. And if there is a large break through which you can easily approach your fluid needle, then the fluid can be drained from the break itself. So this is a small this is a small procedure for creating a retinotomy. The way I do it, I use the endocautery to create a small uh, tiny break, and then with the fluid needle actually to enlarge that break so that the fluid can be drained through it completely. And these are usually resorted in when there are small breaks at the periphery. The posterior breaks, as I mentioned, drain from the extrusion needle by tilting the eye, and that's again a very important step, that you tilt the eye and to so that all the fluid comes to that point where you can drain it completely during the air fluid exchange. So when we address and we come across a bullous retinal detachment, it is important then when we start the vitrectomy, when you start the core vitrectomy, to drain the fluid so that the elevation of the retina becomes less and it doesn't get incarcerated in the cutter. So this is a little video showing the start of the vitrectomy, where you can see there was a small break, and I'm trying to drain it through the break right at the beginning after doing a basic vitrectomy, and you can see that the retina starts to settle down nicely once you drain the fluid. And once the retina settles down completely, then it will be easier and safer to complete the vitrectomy, because there's a high danger of incarceration or making further breaks if you try to do it at the time of the bullous detachment. So, what are the pearls that when we are doing these procedures, one has to be patient. We need to make sure that there is a very good view before we start the air fluid exchange. The start of the air fluid exchange with the extrusion needle just above the break to create a communication between the subretinal fluid and the extrusion needle. And once the channel is established, then you start the fluid exchange. So whenever you are going for the fluid exchange, it is important you reach out at the break, start, instead of pushing the air in, just start draining the fluid without air, and then the air pump starts when the channel is established. Do not remove the fluid needle until the fluid is completely drained. This is a challenging step, because sometimes the air bubbles, they create visual problems. But once you are sure that you are at the right position, just be patient and you will see that the fluid will be removed completely. And normally when I start the air fluid exchange, it is up to around 30, 35, and then I reduce it to 20 to 25 millimeters, so that I need some time for the fluid to be drained. So I need to be slow. So once we have done that, then we are coming to the treatment for the break. So obviously either we do endo laser or we do cryotherapy, or both. Endo laser can be localized depending upon the breaks. If there is a single break, multiple breaks, or there can be 360-degree, for example, if there are multiple breaks in all the four quadrants. And sometimes it's hard to find a break, but there is certainly a rhegmatogenous element. So you do the retinal detachment and then do a 360-degree laser. The localized laser is done 3 rows of laser around the breaks, gentle whitening effect, and normally the settings, it's personal choice, but in my settings in Constellation I use 150 power, 100 millisecond duration, and 300 interval. So 360 endo laser again is important in certain cases, 3 continuous rows posterior to the ora. And cryo usually I use in these cases where the patient is phakic and there is a peripheral break. It's difficult to reach out there with the laser, and high touch of lens, high chances of lens touch. So in these cases, I would prefer a cryo. But again, when we're doing the cryo, it is important that you are in the right position. The bigger breaks with the cryo, the issue is that the retinal pigment epithelium can be sprayed into the vitreous cavity with the chances of PVR later on. So generally, you try to do the cryo to the edges and avoid doing cryo multiple times at the same location. So this is a video for the laser after the retina is reattached on the brakes. Again, I've explained that basically 3 continuous rows should be applied. The gases, I think Dr. Bilal has very nicely explained about the gases, so I would not go into detail for that for the sake of time. But just to mention that SF6, we know it's shorter duration. C2F6, this is what commonly used in my hands. C3F8, longer duration. Coming to the silicone oil, 1000 Stenti-Stoke, 2000, 5000 on heavy oil. Densiron I use quite frequently for inferior pathologies. Mainly, I would not go into these details, maybe mention a little about heavy oil. I don't know how many of you use Densiron, but in the inferior pathology, in my hands, I think it's a good tool and it works very well. Sometimes people are concerned about the removal of the oil, but this is a quick video. It shows that you can remove the Densiron easily. All you have to do is high settings of high vacuum, keep the extrusion into the silicone oil bubble, and with the high vacuum, you will lift the bubble completely and remove it. So buckles, again, I won't go into details, bands, sponges, we're all I think we're running out of time. So I'll just go to the final steps, conclusions. So retinal reattachment surgery is a vision-saving procedure. The management starts in the clinic. That's the key. Detailed examination, including biomicroscopic slit lamp examination, indirect, indented examination is vital. The procedure and tamponades, internal or external, are planned in the office rather and executed in the theater. An extra half an hour spent in the clinic and in theater will give patient miles of vision. Thank you very much.
Thank you, sir, for sharing the pulse of vitrectomy with us. Our next speaker is Dr. Faisal Murtaza, and he will be talking on evolving frontiers in surgical management of subretinal pathologies.
Assalamu alaikum. Thank you very much to arrange a very excellent session on the vitreoretina, and I congratulate Dr. Huma Kiani to arrange this session. My presentation is on evolving frontiers in the surgical management of subretinal pathologies. Etiology. What are the causes of subretinal hemorrhage? Either age-related macular degeneration, high myopia, trauma, uveitis, ruptured retinal artery macroaneurysm, Valsalva, retinopathy, sickle cell disease, and most important, central retinal vein occlusion and diabetic retinopathy. Then there are different surgical options to remove, either remove with or without use of TPA, pneumatic displacement, and surgical removal of the CNV. My case number 1 is subretinal hemorrhage. And you see in this video a large retinal microaneurysm here that leads to hemorrhage. So what we do after performing the vitrectomy, we did the retinotomy and then try to remove with the help of this cannula, but unfortunately cannot remove it. Then with the help of this retinal forceps, we go behind the retina and then pick it and then remove it. The whole blood clot is removed with the help of this forceps. Then clear the blood subretinal, perform the air fluid exchange, flatten the retina, do the laser, and then inject the gas. This is case number 2. You see on the photograph there is subretinal hemorrhage with subretinal exudates. This is the OCT. Now perform the pars plana vitrectomy. After that, you see the difference between the superior and inferior blood. The inferiorly this is sub-ILM hemorrhage, while the superiorly this is subretinal hemorrhage. So with the help of this ILM forceps, we remove the ILM and then remove the blood from the sub-ILM. So address the ILM first, remove it, and then clear the blood with the help of vacuum. Now perform the retinotomy and clear the subretinal blood first. But because this blood is subretinal, and then with the help of forceps, I remove this subretinal hard exudate, perform the air fluid exchange, and inject the gas. This is the second subretinal pathology which we come across and manage it. This is the post-operative. This is the OCT of the patient after surgery. This is case number 3. What you see in this case from the audience? There is subretinal neovascular membrane with subretinal hemorrhage. So in this case, we perform the vitrectomy, do the retinotomy, and then with the help of this forceps, we remove this subretinal neovascular membrane. And in this case, my experience, which I would like to share with you, it was removed with the help of cutter easily. I don't know what is its consistency, but it is removed with the help of cutter successfully. Perform the air fluid exchange and laser. Now the third case, fourth case. This is subretinal neovascular membrane with scar. In this case, I did the cautery of the peripheral retina. After that, perform the retinectomy temporally, and then retract the retina on the nasal side with the help of this soft tip cannula. Gently take it off, and then after that, with the help of this forceps, slowly and gradually, आराम से, not कोई जल्दी नहीं करनी है, very gently. It takes 4 hours to perform this surgery, so perform very gently. Increase the height of the bottle so that bleeding cannot come across, and then peel it like this, and then you see the whole membrane is removed successfully. Now, the very important stage, I try to remove it with the cutter, but unsuccessfully I cannot remove. Then I use phagophragmatome in this case and try to remove it, but unfortunately again I was unsuccessful. So I plan it to remove with the help of forceps by enlarging the incision, because it was very rubbery consistency. Consistency of this membrane was rubbery, so it was cannot be removed with the help of cutter. So I remove with the help of forceps from the outside. You see, pick it with the forceps and then take it out. Later on, inject the PFCL, do the laser, and then inject the oil. Thank you so much.
Thank you, sir, for showing us such daring surgeries and encouraging us to do so. Next presenter is me. I am Dr. Khurram Chauhan. Assalamu alaikum. I am Dr. Khurram Chauhan. I am working as a consultant ophthalmologist at Sir Gangaram Hospital, Lahore. And today I'll be talking on the heavyweight solution, how Densiron is changing vitreoretinal surgery. Today we will be exploring an important tool that has changed the management of most of our complex or challenging cases involving the inferior retina. Most of the, as a VR surgeon, we all have encountered such situations in which we have done all the work and meticulous vitrectomy and great laser, but still the conventional tamponades could not hold the retina, or it could not do its job when it has to do, and how it has to do. So the Densiron is a very sorry. So Densiron, the heavyweight solution, has a unique combination of providing tamponade to the inferior retina, as well as providing the support to the inferior retina, and giving us the support and help us in the reattachment of inferior retina. So regarding its start, it was first in 2005. Wong Kim et al. Described the heavy silicone oil as heavier than water, and it has a good response in providing tamponade to the inferior retina. Then in the next 2 to 3 years, early case series was done, establishing the success of Densiron 68 in complex inferior arteries. Then in the 2019, the Caproso et al. Reported that in 49 case series, reported that it has a success rate of 61.2% in primary reattachment surgeries, whereas 81.6% in the final reattachment, and the main temporal duration was used was 3.5 months. So what is Densiron? Densiron is basically mixture of perfluorohexyl octane, also called F6HH8, and 69.5% mixture of standard silicone oil, 5000 standard silicone oil, which is also called PDMS, polydimethyl siloxane. The purpose of the or function of F6H8 is it is heavier than water and provides the inferior retina, whereas the purpose of the 5000 centist so silicone oil is that it has viscosity, and it prevents the emulsification of the oil. How it acts as a basically weighted cushion. It sinks down on the inferior retina while displacing the aqueous and providing the it has a surface tension which is comparable to the silicone oil, so it seals the and seals the breaks well. Whereas the it has it also it is also noted that it also displaces the inflammatory mediators which are present inferiorly and displaces them away from the inferior retina, thus preventing proliferative proliferative vitreoretinopathy. When we compare it with the standard silicone oil, it has a specific gravity of 1.06, which is heavier than water, whereas standard silicone oil has a specific gravity of 0.9% gram per centimeter cube, whereas its viscosity is 1349 centistores, whereas heavy 5000 silicone oil has 5000 centistores viscosity, and it has surface tension 19.3, which is slightly lower than the standard silicone oil. Therefore, it is most predisposed to emulsification by sharing or impurities, whereas standard silicone oil has a surface tension of 21, and chemical composition we have already discussed. So when we compare it with the standard silicone oil, it has advantage of providing provide inferior tamponade, high detachment rate for the inferior RD, and it reduces the inferior PVR. Whereas disadvantages are it has a retinotoxicity if it is kept longer in eye, and it is difficult to remove, and it's in our setup it's quite expensive, and it has a higher early IOP raise rate. Whereas standard silicone oil, it is easy to remove with we are very familiar with this handling, but it is ineffective for the inferior breaks without 100% filling or posturing. There are different types of heavy silicone oil. The most commonly used is Densiron 68. It has a viscosity of 1349, and it is most commonly used. Whereas a new addition is Densiron Extra, in which the viscosity has been increased to 5000 centistrokes. It is more stable and it has lower emulsification rate. And Oxane HD is also a good alternative to the Densiron 68, and it has a viscosity of 3300 centistroke, whereas or previously Densiron 64 was used. Now it's not used anymore. And regarding indication, the more common indications are primary. In the primary surgery, we can use it for rheumatogenic inferior arteries involving breaks at the inferior retina, giant retinal tears involving the inferior retina, complex cases having extensive PVR, like full thickness retinal folds, or with contracted subretinal folds, or this star retinal folds with star folds. These are the good options and for the usage of Densiron. We can also use for recurrent rheumatogenic retinal detachments after gas or standard silicone oil use, and when patient factors doesn't allow us to use the standard silicone oil, like when post-op posturing is impractical or not possible, or posturing is contraindicated, then we can use Densiron. Adverse effect in phakic eyes, the most common adverse effect is cataract formation, whereas in non-phakic eyes, according to Caprosi et al., which was a study done by Caprosi et al. In 2019, there was incidence of raised ocular hypertension in 34%, whereas other studies showed different report range. It is 10 to 50%, whereas 50% of the patient had transient intraocular pressure raised, whereas in 76% there was persistent raise in the intraocular pressure after removal of Densiron. Emulsification rate is also variable. It is 1.6 to 17%, whereas it is very minimal with Densiron Extra. And sometimes Densiron is also associated with intraocular inflammation, which is 13 to 20%, but it responds very well to the steroids. And other rare complications are corneal decompensation. Contraindications or relative cautions should be taken in active severe anterior segment inflammation. If there is risk of anterior dispersion or emulsification, then the inflammation can flare up, or there can if there is pre-existing endothelial disease like corneal opacity, then there are reports of corneal opacification and if it is used for longer time. And uncontrolled glaucoma, we should be cautious in the patients having uncontrolled glaucoma, as it has a 35% rate of having ocular hypertension. Now comes when to remove the Danceron. The manufacturers recommend it for 60 days, but there are studies which have used it for 1.5 months to 6 months. And what are the indications for early removal? If there is persistent elevated intraocular pressure, or there is emulsification or anterior migration of the Danceron, or there is corneal compromise. And we can delay its removal if the retina is unstable, or there is ongoing PVR. When the and we have to wait the removal and its usage. It's sometimes we are very afraid of removal, and here are some tips to make it easy, so that Danceron can be easily removed. Number first is the first we have to set aspiration at low. We initially, when we start removing, initially we have to make the aspiration low, so that there should be no jetting and or no sudden chamber collapse. When it has established the contact with the silicone oil, then we should raise it to 500 or 600 millimeter of mercury. The second tip is the most important, that is, we have to keep the cannula tip in the oil bubble. The oil must be in continuous in contact with the aspiration cannula till the whole of the Danceron is removed. This is a video showing that the importance of the contact of tip with the Danceron oil bubble. So the trick is that the cannula tip should always be in contact with the Danceron bubble, and will never let it lose contact with the bubbles. If the contact is lost, then there will be sudden collapse of the vitreous cavity. There will be traction on the retina, as well as the bubble will fall on the optic nerve, or the posterior pole. Then it will be difficult to retrieve. And there is another Yes. There is another golden tip, that we can use IV granula 20 gauge can be used if Dancelon settles down in the over the disc. This is a IV cannula which is cut according to the length of the eye. Then this cannula is made in contact with the Danceron near the optic disc, and suction can be applied through this 3D through this cannula, and it can be easily removed. And small bubbles which are left at the end can be aspirated easily with the help of cutters. There are some myths. Danceron is retinotoxic. Yes, it's retinotoxic, and there is some incidence of cystoid macular edema. But if there is emulsification or increased duration of tamponade, then it can cause retinotoxicity. And other most important thing is that can it emulsification does it emulsify? Emulsification reported variably 1.6 to 17%, but it is very less with Danceron extra. The take home message is prefer Danceron for recurrent inferior RDs, inferior PVR, large inferior retectomies after standard silicone oil or gas failure, before injection meticulous heavy silicone oil, heavy liquid and silicone oil removal should be done, and plan 3 to 6 months removal if retina is stable, and remove early if there is emulsification, uncontrolled IOP, or corneal compromise. And during removal of densin, always keep the cannula tip in the oil bubble. Thank you. The next speaker is Dr. Amir Avansa, and please welcome, sir.
So I think it's different from the theme of the session. It's endophthalmitis talk. Unfortunately, I've been put in here. So I'm going to talk about changing landscapes in endophthalmitis. So it's one of the dreadful complication of surgery. Either we are doing cataract surgery, trabeculectomy, or any other intraocular surgery. Even in vitrectomy, it can happen. It's although rare. Or trauma can also lead to endophthalmitis. And sometimes even no injury or anything, endogenous endophthalmitis can also happen. So the background study, which we all know about, is endophthalmitis vitrectomy study. That was in 1995. And that was one of the only randomized treatment in which there was a comparison between vitrectomy as well as intravitreal and intravenous antibiotics. So that was a phase 3 multi-center trial, and inclusion criteria was bacterial endophthalmitis after the cataract surgery and within 6 weeks. And they included the patient's vision 20/50 or worse, light perception or better. And if somebody had a pre-existing eye disease that limited the visual acuity already, those were excluded. Any other intraocular surgery, that was also excluded. And any treatment for endophthalmitis before presentation were given, they were also excluded. So what was the randomization? One thing was that either pars plana vitrectomy as well as intravitreal antibiotics are given, and the other arm was initial anterior chamber vitreous tap and then injection of intravitreal antibiotics. So systemic antibiotics, what they used at that time, unfortunately we don't use that anymore, and we don't know about the role of fluoroquinolones, that how better they are, but they used at that time amikacin and ceftazidime, and they didn't find any difference in final visual outcome. Hand movements of better vision, they have given the verdict that it doesn't make any difference, either you are going to use intravitreal antibiotics or vitrectomy. However, if the vision was perception of light, they have showed the excellent result or better result in case of the vitrectomy group, and twofold better chance of achieving 20/100 or better in the arm which had vitrectomy early. But there were limitations. At that time, it was extra capsule cataract extraction, that was a common technique, and it is just bound to the acute onset endophthalmitis. And no recommendations were made regarding the systemic fluoroquinolones. So recently there is ESRS study in which they looked at the American registry, and they talked about intravitreal antibiotics versus early vitrectomy in the cases of post-intravitreal injection endophthalmitis. So as we know that injections are routinely performed, and they are performed in very large numbers. If you look here, 17.5 million injections between 2014 and 2019, according to Medicare data, 7 million injection annually. And even if we look at the rate, 0.02 to 0.056%, but that makes 2,000 to 4,000 cases per year just related to intravitreal anti-VEGF. So current landscape, what it is, no statistically significant visual difference between treatment of post-injection endophthalmitis. So question is not that does vitrectomy versus antibiotic result in better or worse visual outcome. Important thing is that do clinical and demographic data that modify the effect of the treatment or our visual outcome? So two major questions were important in this study. Among those who received the same treatment, which patient did better or worse? And second important thing, do certain type of patient benefit more from antibiotics versus vitrectomy? So if you look at the question one, multivariate linear regression model, We can see that the antibiotic pseudophakic patient, they did well in antibiotic group. Blepharitis patient even did well. However, the patients who had a glaucoma surgery, they had a worst outcome. Similarly, in a vitrectomy group, they were although better in comparison to the antibiotic groups with the early vitrectomy, but still their outcome wasn't great. The question number 2, other demographics, age hasn't had an influence, race, blepharitis, pseudophakia, but it favored that the glaucoma surgery patient did well with the vitrectomy. So that was their conclusion, that the prognostic factors were the pseudophakic, incisional glaucoma surgery. But the important thing here is that earlier you treat your patient. If somebody has got endophthalmitis, you need to treat very quickly. You need to do vitreous tap, you need to do anterior chamber tap, and they need to be injected with antibiotics immediately. Even if you have theater available or not, you can just use the clean room and you can do that. So let's go to the videos. So the first one is post-intravitreal. So here the patient had significant cataract as well. So my plan was to do cataract extraction as well as vitrectomy in this case. So you look how bad. So usually intravitreal anti-VEGF induced endophthalmitis is really bad because organisms are penetrating more in the vitreous cavity. Usually there is a lot of the optic nerve as well as vascular involvement. So you can see vitreous is quite muggy in this case. So I'm gradually removing all the floaters here. And regarding posterior vitreous detachment, if you can easily induce it, definitely go for it. But if you feel that it's very adherent, and especially in the patients who are diabetic along the arcade or slight mid-peripheral areas, sometimes you can't create the breaks. So you have to really watch it. So here you can see the vessels, they are involved in this case. You can see that even the disc is involved. Vessels are a whitish cord-like appearance. Vessels are, so once done it, fluid exchange, intravitreal antibiotics injected, and in this case, I didn't use any silicone oil. So bleb-related endophthalmitis, they are usually the bad one, unfortunately. So here, there is abscess in the bleb area. Anterior chamber is also quite badly involved. So here, what I'm doing is I'm putting the anterior chamber infusion maintainer first. I would like to clean my pupil area. So I'm cleaning that area. So once I have cleaned, you can see that the sheet-like membranes, they are coming off, and you can start seeing the iris once we are removing these membranes. And here it's the bleb area, you can see that. So you want to see that it's not leaking over. If there is a leak, you would like to repair the bleb area. So now I'm moving to the vitreous. So I'm cleaning the anterior vitreous. And once done that, here you can see there is not much vascular involvement in this case. So earlier you intervene, it's always better and the better outcome you are going to get. So finish up the vitrectomy, intravitreal antibiotics, and even in this case, I didn't use any silicone oil. So most of the cases, if the retina is healthy, you don't need to have a silicone oil tamponade. So next case is a post-cataract surgery endophthalmitis. So here you can see that how the vitreous is looking like. So initially you can see a lot of the pussy material in the anterior chamber. So once if I'm going here, you can see that a lot of membranes, a lot of the whitish stuff that is in the pupil area, because if you're not going to clean it, you're not going to see the vitreous, that how does it look like. So here I'm doing 27 gauge. So once I've done, still I'll keep that infusion. I haven't gone because I can't see clearly in the vitreous. So it's always better. You don't know, sometimes your infusion cannula doesn't go properly in. So it's better to keep the anterior chamber. So I'm removing anterior vitreous first. And once that have been removed, we can move forward. So here I have induced the PVD. And you try to go as much peripheral, but you similarly want not to damage the peripheral retina when you're doing it, because it's more harm if you're going to try to clean at the periphery and you create a break. Creating the break in infective eye is not a good idea. Most of the cases, then you have to use silicone oil as a tamponade and even then there is a risk of retinal detachment. And now I'm going with the infusion and putting my infusion normally. I'm injecting the antibiotics and finish up my case. So when I'm injecting, usually I try to observe from there. So I'm seeing I'm not putting direct jet towards the cornea, not damage. So here, the beauty of 27 gauge is just pull that out and you don't need to have much massage or anything. So here, if you look at that, how bad this eye was, once I cleaned that, still you can see multiple retinal hemorrhages, disc is involved, vessels are involved. So these are the cases, visual outcome may not be great. And the problem is that these are slightly long-standing or more virulent organism that can cause this sort of thing. Coming to the traumatic endophthalmitis. So here, what happens, not endophthalmitis, you can get traumatic lens abscess as well. So in such cases, it's actually not the cataract. Basically, your lens is having the abscess. So you need to have a cataract extraction there. So I'm doing it first. And sometimes you get surprises. Your posterior capsular has got the defect in these cases because infection is so severe. It has created the damage to the posterior capsule. So you have to look for. So here I'm inducing the PVD. And if the infection remains severe, sometimes I have seen even fungal cases, you can develop retinal breaks. Multiple retinal breaks can develop. So this again is very bad condition. So once I have cleaned up, I have putting the lens now. And after putting the lens, suturing is important in such cases. Don't be shy. Wherever you feel your wound shouldn't be leak over. Either sclerotomy wound, I'm doing 27 gauge, 25 gauge, I don't do 23 gauge. So, but even in these cases, if I feel my wound is leaking, I would suture it up. It's no harm in doing it that. And still you can see the white. In this case, I have used the silicone oil. In traumatic cases, I have the tendency to use silicone oil more in such cases because I've seen the better outcome by using silicone oil in such cases. So coming to the conclusion, I think most important thing whenever we are dealing with endophthalmitis cases, you have to deal it immediately. The problem is that we as a surgeon, we don't accept that we can get endophthalmitis. So initially we deny ourselves. We say, no, it's just inflammation. It's just a superficial infection. If there is an vitreous, there is opacities, always it's endophthalmitis. Either the patient is getting pain or not, just ignore that. It can be varied. Some people have got the different threshold. Always assume that it's endophthalmitis. You have to vitreous tap, you have to do anterior chamber tap, you have to inject immediately. Because some patient, just you need to do that. And as we have shown from the American data, initial treatment after even intravitreal anti-VEGF induced endophthalmitis, it improved a lot. And urgently we have to treat these patients. If no improvement, I wouldn't say, I will wait for two days, I'll inject. If no improvement, I'll go for vitrectomy. I don't wait. I don't go immediately, but I don't wait further. I will go for doing it. Same with the endogenous as well, initially intravitreal, but I would go. And usually it's very important. It will prevent, even if the visual outcome is not great, you can prevent the phthisis in such patients. And silicone oil tamponade, not in all endophthalmitis cases you are required. Selected cases, yes, if you develop breaks, it's better to do it. And even the traumatic cases, it's always better to use the silicone oil. Thank you very much. Thank you.
So, do you think that using silicone oil would be more beneficial rather than using any gas in cases of endophthalmitis because of the pro-anti-inflammatory action of silicone oil?
Not in all cases. As I said, most of the cases I don't use. I either use air or maybe gas if I want to have some tamponade. There is no break or anything. I don't do any laser. I don't do anything at all. However, if there are breaks there, definitely I will do the laser to the breaks area. Most of the cases, in some cases, if it's a small break I've created, I may still go with a gas tamponade. But most of the cases, what I have seen, usually the break, retinal detachment, and infection, they don't go along well. So it's always better to use oil in those cases. It's no harm using it. You can remove it later because I remember one of the case actually presented late. I had intraocular foreign body as well. Not a good experience. So I put the gas initially, and that patient turned out to be a very giant retinal tear he developed later. And later I have to go back again. I have to put the oil. I have to do a couple of surgeries more. So his eye saved. Unfortunately, vision-wise, he came to me late as well. The projection was faulty at that time. So it's always better to, in traumatic cases, better use it silicone oil tamponade.
So, are you comfortable putting the IOL in the same surgery or defer it?
Yeah, I will have put in same surgery.
Same
So I
surgery.
have low threshold for like the case I've shown. It's a post intravitreal anti-VEGF. So that lady actually had anti-VEGF injection. She developed endophthalmitis. She contacted. Nobody responded. 2-3 days delay, and then she came, and then even no intravitreal antibiotics given. Was referred to me, and I immediately took her to same day. So in that case, she did really well. Her vision is 6/9. Her eyes saved as well, and yeah, that's so. If I feel that my view will be compromised, I won't be able to see with the cataract. I just do, and I put the lens. So I finished the cataract surgery as normally. Once I finish that, then I put. In the case where I shown the traumatic here, was posterior capsule was ruptured actually. So I wanted to clean it, so I cleaned it that, and then later I put it. But otherwise, I finish anterior segment first, and then I'll move to the posterior segment. And there is no harm. Even in, I'm doing more commonly phacovitrectomies even otherwise. Even in retinal detachments, if somebody has got the cataract, I go with the phacovitrectomy. So it's no harm. You can do it.
Thank you, sir.
Tractional detachment, sorry.
If you come across during vitrectomy for endophthalmitis and the patient is having tractional membranes over the macula or away from the macula, would you advise to remove these in the same setting, or would you leave them to avoid retinal breaks, because the retina is very fragile in such cases?
I think it's a good question. It depends how easily you can remove. I try to induce the PVD. I see how the things will be. If easily I can move over, I will remove that. If can't, you try to trim that as much as possible and leave it. And later you can come back and you can remove that. Because you can't remove all the vitreous opacity, even the periphery. As I told, you can remove the maximum amount, but still there will be some remaining. You can't remove that completely. Because if you try to, there are chances that you're going to create atogenic breaks there. So you can leave it and they will clear up. So even sometimes the membrane leaving there, they will clear up. It's just a vitreous opacities there. They are there. They are not true membranes formed there. They're just from the posterior highlight phase. So they will go away once infection.
Nice presentation, Amir. Just a couple of points I wanted to make. We still do get endophthalmitis after intravitreal injections. We do about 6,800. So, one or two here and there, especially young, poorly controlled diabetics, they turn out to be. We haven't had any endophthalmitis following cataract surgery for a long time because we use intracameral apricam, 1 milligram. I don't know whether that's the norm here. Every patient gets it over there. But coming back to endophthalmitis, we do AC tap, vitreous tap, and intravitreal vancomycin, 1 milligram, ceftazidime, 2.2 milligram injection. And if there's no improvement within 48 hours, we repeat. And then we refer to VR. VR won't accept it unless we've done AC and vitreous tap, unless we've injected twice, unless we ask for a PCR to rule out a fungal infection. And we don't start them on any topical steroids. 1 hourly antibiotic drops, usually siloxane or Exocin, which is ciprofloxacin. And we start them on oral ciprofloxacin as well, 500 yes. QDS. So do you guys do similar kind of stuff?
Yeah, moxifloxacin we use mostly orally, but you're absolutely right. The problem here is our colleagues, sometimes they just give IV. I have seen patients like they're having IV antibiotics. It don't help. It's only treatment. Here it's intravitreal. If you're not injecting, we don't know fluoroquinolones, how much they help. We know that their vitreous penetration is better, and we also use moxifloxacin, but we don't know exactly because there are no randomized trial that can tell us about that. But yes, the practice would be moxifloxacin. And TAP is very important because that's going to tell. There are a lot of cases, sometimes they're not sensitive to the antibiotic. Chronic endophthalmitis, acute endophthalmitis, you may get different organisms like serraceous, sometimes I've seen there are some organisms which have very bad outcome. So if you don't know how you're going to manage it, so it's always important whenever you're doing, just take if the vitreous is not coming, anterior chamber aqueous tap, you will get some. So have something, so that we can prove it what sort of
Absolutely. I think you need to know your microbiologist really well as well. Absolutely. And yes. The PCR lab, because they take about 3 days before you get the answer. Yes. So those things are very important. Yeah.
No, no problem. Gas, I'm saying air I use it for these cases. So even air, I'm using it, no problem at all. Because you have cleared all the vitreous thing. So sometimes there is slight muggy appearance would be there because there's a periphery, you have left it. But that gradually clears up. Another thing, what I do is post-op, once I've done the surgery, most of the cases I give oral steroids. So I gave around 40 milligram for 5 days, 20 milligram for another 5 days. So 10 days they are on. So that clears inflammation. Topically, I start the steroids immediately after vitrectomy. I start it at least 6 times a day. I will start on, and like Vigamox, we give it 4 to 6 times as well. Cyclopen, I use it. But no problem with gas or air. It's no issue.
Very nice cases, Amir. Just a quick, just case number 2, you had blebitis and looked like that vitreous cavity was relatively clean. So usually we do a B scan to make sure there is some vitreous opacities prior to entering the vitreous, because you can introduce that infection from the front to the back of the eye. Second thing is that in terms of IOL insertion, I mean, you can have colonies of bacteria sitting in the area which you cannot see. So generally speaking, I mean, it's avoided because you are introducing a foreign body which some bacteria can cling on to. So, I mean, obviously that case had a good outcome, but generally speaking, I think generally people tend to avoid insertion of any foreign bodies, including the intraocular lenses at that stage. So, I mean, is this the isolated case, or you always try to?
No, I to be honest, it depends what sort of the case is. Like chronic endophthalmitis, post-cataract surgery is a different thing. In that case, yes, you wouldn't like. So in my preference now is because a lot of chronic endophthalmitis cases we do get in Pakistan. So what I do is I remove everything. Previously, in some cases, I was doing initially giving the trial, but what I have seen, mostly cases, infection does come back. So I remove the capsular bag, everything I remove it. But not in acute cases. Still, I don't do anything even in other like injections. It depends how your visibility is. If there is not much cataract, I won't go for it. My first preference is to deal with the thing, what we are doing it. But if there is significant cataract, usually my preference is I'll just go with and just do normal cataract surgery. And yeah, luckily no problem. We have.
I mean, usually, I mean, I'm saying that no harm in removing the cataract, but
yes,
not to put an implant lens at that stage.
Yes.
Because I mean, when I was practicing here, there were a bunch of cases with chronic endophthalmitis, and you have to remove the IOL capsular bag, and you then leave them aphakic for a while.
Is that post-injection you're talking about?
No, I'm talking about just chronic endophthalmitis.
Chronic, definitely I remove it. Chronic endophthalmitis, if there's there, you don't want to leave anything. You want to remove the IOL, you want to remove the capsular bag, everything. You don't want to leave it. Absolutely, you're right. In that case, there is no, later I remove it and later I do scleral fixation then in those cases. But I will keep it like 3, 4, 5 months. No inflammation, no infection coming back. Thank you.
Thank you.